Let's start. Today we will do about ECGs. So normal sinus rhythm. Normal sinus rhythm, usually the heart rate is between 60 to 100 beats per minute. Rhythm will be regular and P wave before each QRS. We will see P wave before each QRS complex and PR interval will be 0.12 to 0.20. PR interval. This interval will be 0.12 to 0.20 and QRS will be less than 0.12. This QRS will be less than 0.12. This is sinus rhythm. What is sinus tachycardia? Sinus tachycardia is heart rate. In heart rate, we see beat to beat variability with change in activity and or stress. Usually, it will be less than 220 in infant and less than 180 in children. So, sinus tachycardia may be associated with some stress or some exercise. Okay. And usually, the value will be less than 220 in infant and less than 180 in children. So, PR interval. Again, the PR interval will be normal, constant with normal duration, and the P wave is always present. In sinus tachycardia, P wave is always present. It will be always present and it is normal. And RR will be variable. This RR can be variable, okay? But the P wave will be always present and QRS is narrow and it will be 0.09 seconds. 0.09 seconds. It will be narrow and 0.09 seconds. So in the slide of sinus tachycardia, usually heart rate will be more than 100 beats per minute. The rhythm is regular and you will always see the P wave and it will be identical. And the PR interval can be 0.12 to 0.20 and QRS will be shorter compared to the normal sinus rhythm. It will be less than 0.12. If we see so, heart rate in this slide is around 135 beats per minute. And sinus tachycardia causes, we should know, the causes of sinus tachycardia is anxiety. It will be exertion, that is like exercise. It can be fever and some drugs and hyperthyroidism. Let's start with SVTs now. Paroxysmal SVTs. SVT means supraventricular tachycardia. So what is it? Abnormal fast rhythm originating above ventricle. It is called supraventricular. That the name itself tells you it is supraventricular. That means this rhythm is originating from above the ventricle and it is abnormally fast rhythm caused by re-entry mechanism that involve the accessory pathway or we all know that the SA node, then this AB node, then we have Purkinje fiber and we have other. But here we will have, in the case of SVT, we will have an accessory pathway. So this is caused by re-entry mechanism that involve the accessory pathway of the AV conduction system. It is the most common tachyarrhythmia causing cardiovascular compromise during infancy. So, any infant presenting for you with more than 200 or 220 beats per minute, you should always rule out supraventricular tachycardia. Here we read. See, we read here, in an infant, less than 220 can be sinus tachycardia, but if it is more than 220, definitely you have to rule out SVT. And in children, less than 180. It should be tachycardia more than 180. You have to rule out SVT. So it is the most common tachyarrhythmia causing cardiovascular compromise during infancy. The paroxysmal, because it occurs episodically. Why do we call it as paroxysmal? Because it occurs episodically, and the rapid rhythm start and stop suddenly. Means paroxysmal. Suddenly it starts the rapid rhythm, and it might stop also. It might abort by itself as well. So it will be sudden starting, suddenly it will start, it will be very fast, and sometimes it can abort by itself. So it is called paroxysmal. This is the reason. Now clinical picture. Clinical picture is, it will be a rapid regular rhythm. You will have the features of palpitation, dyspnea in children. SVT can produce signs of shock. It can produce signs of shock in congenital heart disease. In children, SVT may be exacerbated by exposure of non-prescription decongestants or bronchodilators. So that's why we have to be careful in using decongestants in children. See what he's telling, in children, SVT may be exacerbated by exposure to decongestants. I don't know what does he mean by non-prescription. But decongestants can be one of the cause for SVT in children. That's why when we prescribe decongestants to children, we have to be very careful, or better avoid them as much as possible. As we all know that less than 6 years, better to avoid all these medications. And also it can be precipitated by bronchodilators like Ventolin. ECG in SVT, heart rate will be 220 in infants. In infants, it will be more than or equal to 220, and in children, it will be equal to 180 or more than that, with no beat-to-beat variability. There won't be any variability. It will be same. And P wave is absent. Usually, it is absent or abnormal. I don't know about the abnormal P waves. What I know is absent. Then PR interval may be short or cannot be determined in ectopic atrial tachycardia. So RR interval is usually constant. It is usually constant, as we said that there is no beat-to-beat variability. If there is beat-to-beat variability, RR will not be constant. So RR is usually constant, and QRS complex is usually narrow, and it will be too much narrow, less than 0.8 seconds. As we know that normally the QRS will be less than 0.1 to 2 seconds. But here in SVT, even in sinus tachycardia, it can go normal, like less than or equal to 0.09 seconds. But in SVT, it will be still more narrower. It will be narrower than the normal sinus rhythm and rhythm of sinus tachycardia. You can also observe here in the slide. See, it is almost like a line. So you must differentiate SVT from sinus tachycardia, because sinus tachycardia needs treatment of underlying problems such as sepsis or hypovolemia. But SVT needs antiarrhythmic drugs. So the differentiating between sinus tachycardia and SVT is very important because the treatment is different. For sinus tachycardia, usually we will treat the underlying cause, but for the SVT, we need to give antiarrhythmic medications. So sinus tachycardia is gradual in onset, but SVT is abrupt onset. That is why it is called paroxysmal supraventricular tachycardia. Sinus tachycardia, signs of the cause such as fever or anemia. SVT, you will see signs of heart failure. So he is just writing for you the difference between SVT and sinus tachycardia. P wave is present and normal in sinus tachycardia, but absent and abnormal in SVT.
Doesn't have notes. Of course, these are concerns about job displacement and ethics.
Chest X-ray is small heart in sinus tachycardia, but enlarged in SVT. Sometimes, as we said, there can be heart failure associated with SVT. So you can see a slight enlargement of heart, but it will be normal in sinus tachycardia. But this will not be a major difference for you. You have to find it out from ECG. No one will do chest X-ray to differentiate between sinus tachycardia and SVT. We should speak practically. This is just he's giving a difference. But for us, ECG. So from the ECG, how to differentiate is very important. Now, the heart rate. Heart rate more than 230 with abnormal P wave. Normal P plus in lead 1 and AVF is equal to SVT. Usually, heart rate more than 230 and there will be absence of P waves. But he's telling we can see a normal P in lead 1 and AVF. It's usually SVT. No beat-to-beat variability. That means the RR will be constant in SVT, but variable in sinus tachycardia. Heart rate in sinus tachycardia is variable in vagal or sympathetic tone. Okay, the category of SVT can be divided into 3 major subcategories. That is re-entrant tachycardias using an accessory pathway, re-entrant tachycardias without an accessory pathway, and ectopic or automatic tachycardias. So it can be re-entrant tachycardia. That means, as I showed you before, there will be an accessory pathway here, leaving the normal pathway. This accessory pathway, this is an re-entrant tachycardia from the accessory pathway, or without accessory pathway suddenly. Not that everyone will have this. Suddenly it can start without an accessory pathway, or it can be somewhere else. Not an re-entrant pathway. It can be ectopic or automatic tachycardias. But the common is this. Re-entrant tachycardias with an accessory pathway is the common. This accessory pathway we usually see in Wolff-Parkinson-White syndrome. So let's learn about Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White syndrome. Atrioventricular reciprocating tachycardia involves accessory pathway and is the most common mechanism of SVT in infant. If there is an SVT in infant, you should make an effort after you abort the SVT to check whether this child has Wolff-Parkinson-White syndrome, because here he is very clear. Atrioventricular reciprocating tachycardias involves accessory pathway and is most common mechanism of SVT in infants. AVRT with bypass tract may either be able to conduct bidirectionally or retrograde only. That is concealed accessory pathway. Patients with WPW syndrome have a small but real risk of sudden death. There is a possibility that there can be sudden death. If the accessory pathway rapidly conducts in antegrade fashion, the patient is at risk of atrial fibrillation and begetting ventricular fibrillation. Risk stratification, including 24-hour Holter monitoring, exercise study, may help to differentiate patient at higher risk of sudden death from WPW. So 24-hour Holter monitoring and exercise study can help you to differentiate between patient at higher risk of sudden death from WPW. Syncope is an ominous symptom in WPW, and any patient with syncope and WPW syndrome should have electrophysiology study and likely catheter ablation. So any patient with WPW is presenting to you, maybe in infancy there was SVT, but now he is also present, but as the child grows up, if he presents to you with syncope and diagnosed as WPW, the best option for you is to go for catheter ablation. You have to do the ablation. Although most often present in patients with a normal heart, this syndrome may be associated with Epstein's anomaly of tricuspid valve or hypertrophic cardiomyopathy. One more, another associations with this. It can be present with a normal heart, but it can also be associated with Epstein's anomaly of tricuspid valve and hypertrophic cardiomyopathy. Exercise guidelines in these patients. Guidelines are best made by a patient's doctor so that all relevant factors can be included. Participation in vigorous competitive sports, particularly in adolescent boys, may be restricted until the problem is treated by radiofrequency ablation. Suppose during the infancy, this person has overcome the WBW, or he was being treated medically only. But once the child grows and there is a syncope and he is adolescent age and he is used to do vigorous competitive sports, we have to go, if he should continue his vigorous competitive sports, we have to go for radio frequency ablation. Otherwise, we have to restrict him from doing this. If the pathway does not conduct rapidly from upper to lower chambers, usually no activity restrictions are needed. If the child has an otherwise normal heart. See, there is a pathway, but it is not conducting. It is not conducting from upper to lower chambers. Then it's okay, no restriction is needed. But there is an attack of SVT that you have to restrict till the radio ablation is done for these children. You have to understand. So now let's draw an heart here. This is SA node. There is an accessory pathway here. This is a normal pathway, SA node to AV node, and we'll have this is normal pathway. Now this is an abnormal pathway. What he's telling here is AVRT bypass tract may be either able to conduct bidirectionally. It can either conduct this way or it can also conduct this way, bidirectionally. It can conduct anyways. That's why it is paroxysmal rapid anyhow. Okay. Bidirectionally, and or sometimes it can be only retrograde. Retrograde means going from down to up is retrograde. Antigrade means usually up to down. Okay. Now let's go to